Good afternoon, colleagues. Good morning and good evening, wherever you may be. My name is Willie van Heerden, and I'm head of the Department of Oral and Maxillofacial Pathology at the University of Pretoria. Welcome to our invited guest lecture series. We are today indeed privileged to have Professor Falko Fend give a talk to us, as you can see on screen. Colleagues, it is a pleasure for me to introduce Prof. Falko. He actually needs no introduction in the field of haematopathology. He's currently Professor of Pathology and Chairman of the Institute of Pathology and Neuropathology at the Eberhard Karls University in Tübingen, Germany. He did his medical training, undergrad and postgrad, at the University of Innsbruck in Austria, where after he spent work as a research fellow at the National Cancer Institute, Bethesda, with Mark Raffield and Elaine Jaffe. On returning back to Germany in 2007, he became full professor and head of a department where he established the molecular diagnostic facilities. He initiated research programs in haematopathology, molecular pathology, as well as translational interdisciplinary projects. He is a member of the Executive Committee of the German Society of Pathology, as well as the Advisory Board of the European Society of Pathology. He's been a very popular invited speaker, guest speaker, and he has co-authored and authored, looking at the ResearchGate, around about 750 articles and contributed to major textbooks, including the latest WHO Blue Book on hematopoietic and lymphoid tissues. Falko, thank you very much for being prepared to share with us this afternoon, to spend your time, and we're looking forward to listen to you. Over to you.
Well, dear Willie, thank you very much for this kind invitation. It's a pleasure for me to be here with you today, even though it's only virtually. I probably would have preferred to be in Pretoria in person, but that's a lot more effort from both sides involved. So I'm happy to talk about haematopathology today, and I try to focus a little bit on diagnostic issues, also including new aspects and new entities which have evolved. And I focus on the head and neck region. So, of course, it's a broad area to cover. And so I have prepared a lot of slides with a lot of histology. So in case you're getting bored, please let me know, wave your hand, and I can stop at any time and take questions. I hope you can see my slides moving now. If not, just let me know.
Yeah,
what is my talk? Okay, great. So what's my talk about? So my main issue is how I diagnostically approach lymphatic lesions with a focus on the head and neck region, but it's benign or malignant. And I start off with morphology, which still is the way to go. And I want to take a look at how to use immunohistochemistry focused and efficiently. And for some entities, I will take a more closer look at the molecular, because this is how we have learned more about the diseases, always going back to morphology and reinforcing our knowledge about the diseases. And therefore, we'll point out some novel or rather newly described entities. And along the way, I will use my time to present cases which are typical pitfalls in diagnostic pathology. So I hope this is will take your interest. Talking about pitfalls, this is also a talk about avoiding mistakes. And so the biggest mistake in pathology, as we all know, is to take something benign and call it malignant, or vice versa. So to turn around Jekyll and Mr. Hyde. And especially in haematopathology, there are not so few instances where you can make this mistake. And these are the most difficult cases. And so I have put in a couple of these along the way, and occasionally I will let you a few seconds of time to make up your mind about the diagnosis before I render the diagnosis. So in order to have a little bit of quiz We cannot do it in a participative way, but at least you can make up your mind about diagnosis before I do that. So how do we diagnose lymphomas? Well, of course, we look at a microscope, but first we should also look at the clinical features. But if we look at a microscope, there are two main features which we're looking at, which is the disruption of the normal architecture and which is the atypicality of infiltrating cells. And this is not so much of help in every single case because the disruption of the architecture may only be partial and may not be present in every lymphoma and can also occur in reactive disorders, as we will see. And on the other hand, the majority of lymphomas show cells which you will find in any reactive disorder, unless you have something like this in a plastic large cell lymphoma where you have clearly cells which do not occur to that extent in a reactive disorder. That's why we also need, of course, immunophenotyping. An aberrant immunophenotype, of course, is helpful, but again, this is not something which is universally true for all lymphomas. And the clonality is also helpful, of course, but both B and T cell clonality can occur also in reactive disorders. So clonality should never be interpreted without taking into consideration the whole other picture. And of course, then we have mutation detection and translocation detection by FISH. So what are the difficult lesions which I'm talking about? Well, what is difficult? If you have a preserved or partially preserved architecture, which can be due to an incipient infiltration, you can have a lack of atypical cells, since it's a small cell lymphoma, and you may also have a lack of an aberrant immunophenotype. And on the other hand, extranodal infiltrates often have specific problems because a lymphoid infiltrate in a given extranodal site may per se already be pathological, and the question is whether it's reactive or neoplastic. And we also have a limited repertoire of reactive cells in many extranodal tissues, so we also have problems with interpreting clonality in certain instances, for example, in the skin. And of course, we also have the problem of core needle biopsies, which are getting really a pest these days because clinicians resort to less invasive techniques, which may lead to higher costs of diagnostics and to suboptimal diagnostic interpretation. So I took the approach to look at the different structures in the lymph node and go through the different structures which we encounter in reactive lymph nodes one by one. So if we look at nodal lesions, we have follicular lesions, we have mantle marginal zone lesions, and we have interfollicular lesions. So I'm not going to talk a lot about reactive follicles. You all know how they look like. They should be BCL2 negative, CD10 weakly positive, and have a low, high proliferation rate and moderate number of T cells. They are usually polarized if you look at the proliferation rate. And sometimes these follicles may be very bizarre, like in this reactive lymphadenopathy in an HIV patient, which typically have this florid follicular hyperplasia, but we'll later see that this BCL2 negativity, as in this stain, does not exclude a malignancy in every single case, but we also should take care about these lesions which are BCL2 negative. So to start off easy, we all know follicular lymphoma. This is basically an H&E diagnosis. If you have a fully developed follicular lymphoma, as you see it here, we do immunohistochemistry to confirm the diagnosis, and you see the BCL2 positivity, which is the hallmark of follicular lymphoma. And if you have a grade 1-2 follicular lymphoma, usually you have a low proliferation rate, as shown on this picture, which is also a very, very important hallmark of follicular lymphoma. Of course, you have the BCL2 translocation. So that's fairly easy, and we all know other markers of follicular lymphoma which we can use. We have CD10 positivity, which may be quite intense. We have BCL6 positivity. CD10 and BCL6 are often downregulated if the neoplastic cells go outside of the follicles. Beware of BCL2 positive primary follicles. They should be BCL6 and CD10 negative, but they're of course BCL2 positive. There are some additional markers. We like MEF2B for follicular cells, but I think this is basically basic knowledge for everybody here. But you may encounter cases like this, and this is actually something which you as a head and neck pathologist may encounter very frequently. So if a 66-year-old female, you have this lymph node. So this is a neck dissection, and you look at this and see, okay, this looks like strange. You have some areas which look like T-cell hyperplasia, and then you have these weird-looking follicles, and you have some which look pretty normal. And if you go further and you see, okay, this follicle has some centroblast, whereas this looks very monotonous up here. And then you go on and do immunohistochemistry, and you see they're BCL6 positive, they're CD10 positive, but they have a very low proliferation rate shown here in the MIB1 stain. And the next thing to do is the BCL2 stain. And then you have a partial involvement by follicular lymphoma, which is not so uncommon. If you do retrospective studies from oncological surgery specimens, you will encounter these partial involvements not so infrequent, so which are underdiagnosed, but it's actually not a real big problem for the patient since it's such an indolent disease. And here where you see the yellow arrow, you see a normal looking germinal center, which already has a sprinkling of BCL2 positive cells in there, which is what we now call in situ follicular neoplasia, something I will address a little bit later. So this preserved, partially preserved follicular architecture or partial involvement of a lymph node by follicular lymphoma is actually associated with limited stage disease. This was an observation made many years ago. So 80% of patients which have this partial involvement actually still have stage 1-2 disease in this study, and this holds on in other studies as well. So this is an indicator that these patients have limited stage disease, which is important information for the clinician. This needs to be discerned from this lesion, which is called in situ follicular neoplasia, which I mentioned beforehand, which is a normal looking lymph node, which has strongly BCL2 positive cells, only localized to germinal centers. Many germinal centers are still there. And by definition, these lymph nodes should not have an alteration of the architecture. The lymph node I showed you before, you clearly saw there was something wrong. But here, this looks like a very normal lymph node. So you will ask me, how do I detect this? Well, you shouldn't detect it at all, because in situ follicular neoplasia is actually something which you find commonly. We did a large study and we found it in 2%, 2 to 3% of normal individuals in normal reactive looking lymph nodes. So this is a precursor lesion, which is very common, but the risk for transformation to follicular lymphoma is low. So you should not look for these lesions. And if you encounter that by chance, you should report it. The patient should be staged clinically, but they should not receive treatment. So don't look for those. If you come across them, just report them as what they are, a preneoplastic precursor lesion. These are the differential between partial involvement and in situ follicular neoplasia. I'm not going to go into detail. You should not have perifollicular spread, and morphologically the architecture should be completely preserved, unlike in partial involvement by follicular lymphoma. So this was kind of a warm-up, but what do you do if you have something like this? You see the picture on the left, and you say, okay, this is follicular lymphoma. And then you do the BCL2 on the right, and you're getting disappointed and you're getting worried. So what is this? Is this still follicular lymphoma? If you look at the MIB1, which is very helpful here, this is not a reactive germinal center. It's not morphologically, it's not by proliferation rate. So we know that about 10 to 15% of low-grade follicular lymphoma, so grade 1, 2, are actually BCL2 negative by immunohistochemistry. But there are different types of BCL2 negativity. One type is that they are truly negative, and the other type is that they have a mutated BCL2, mutated by somatic hypermutation, and they have, and then you use a different clone. We use the E17 clone, and then these cells are positive. So these carry also the 14-18 translocation. So this is false negativity by immunohistochemistry, which is due to conformational change of the protein so that the antibody cannot dock anymore. This is something which is nice to know, but not really relevant diagnostically. But there are different types of BCL2 negative follicular lymphoma. One is these 14-18 positive cases, which have this mutation. And the others may either have a BCL6 translocation, which then are also follicular lymphoma, or they have neither BCL6 nor BCL2 translocation. And this was first recognized by the Würzburg group a couple of years ago, and they found these cases to be frequently with diffuse areas, frequently with CD23 expression, frequently in the inguinal region, and more frequently females, and they had an 1p36 deletion. And we have recently done, under the guidance of my wife, Leticia Quintanilla Martinez, a large study on follicular BCL2 translocation negative lymphomas. And if you look at them by a molecular level, you can actually subdivide them and many of them into 4 different groups, which have different clinical pathological characteristics. You can read this. I'm not going to go into detail, but one thing is important. Many of these cases have STAT6 mutations. And if you have a STAT6 mutation, there's downstream activation of CD23, and then you have CD23 expression. So if you have something which looks follicular lymphoma and is CD23 positive, this is not a mistake of your immunolab. This is probably one of these cases of follicular lymphoma BCL2 negative with CD23 expression. And this is a nice summary of these cases. So in the left lower corner, you see the different types of follicular lymphoma. You have the conventional follicular lymphoma, and you have the 14/18 negative ones, which fall into different groups and frequently show a STAT6 mutation with co-expression of CD23. Otherwise, clinically, some of them have limited stage, frequently is immunopresentation, and otherwise they're very similar to conventional BCL2 positive follicular lymphoma. However, not everything which is BCL2 negative does belong to this group. This is a case from a 15-year-old male with a large cervical lymph node. And you can see a part of the lymph node seems to be preserved with small germinal centers, open sinuses. And then you have this conglomerate of large follicles, which have a starry sky pattern. The follicular mantle cells are not very well arranged. This is kind of medium-sized blast, so it's not really centrocytes and centroblasts in many of these cases. If you look at the Gimsa stain, you see the starry sky pattern and these medium-sized blastic cells. And then you start to wonder, should I do immunohistochemistry on these stains? And you see you have a node-in-node pattern, the CD20 stain. You have normally reactive follicles, these huge serpiginous follicles, which are BCL6 positive, have a high proliferation rate, but not really polarized like you would expect them. They're CD10 positive. The follicle mantles are not very well defined, but they're still usually BCL2 positive. And then you do CD10, you have a very strong overexpression of CD10 as compared to the reactive follicles, so quite strong usually. And then you do clonality and you have a strong polyclonal background, but you have a clearly reproducible pattern. And so this is pediatric-type follicular lymphoma. So this is typically cervical nodes. It's typical young male patients, extranodal sites and other locations tested in a similar lesion, but different in a way. Usually it's grade 3 morphology, so follicular lymphoma grade 3. They have follicular markers, but are usually BCL2 negative, and they don't have a 14/18 translocation. They have 1p36 deletions and DNSFR SF14 mutations and MAP2K1 mutations. Some cases like this may occasionally be observed in young adults also. So it's not that they stop after the 18 years. They are very indolent, so you should not treat these patients after excision. So this is a very specific type of lymphoma. They're almost always stage 1 and don't require chemotherapy. So we stay with the follicular lesions. This is again in the head and neck region, as I promised you. It's a young patient again. And this had a long-standing history, 2 years of a slowly increasing lymph node. And the lab findings were normal. The patient was feeling normal, but the lymph node was quite big. And if you look at the lower power, you see this weird follicular structures, which have some of them multiple germinal centers. And if you look closer, then you see, okay, the follicles are CD20 and the interfollicular areas are CD3. So this looks normal. And you see these concentrically arranged lymphoid cells, and you see that the germinal centers are actually contracted, regressed. So you will already see, you will already know what this is, because this is a very typical diagnosis. If you look at the other markers, you see IgD, these are follicular mantle cells. The germinal centers, which are regressed, are still BCL2 negative, CD10 positive. They have CD23, also in the follicular mantle cells, so everything looks fine. And by chance, you did the CD5, and you see that all these follicular mantle cells are CD5 positive. And you say, oh my God, what does this patient have? Is this mantle cell lymphoma, 20 years old? It was a mantle cell pattern, so cyclin D1 is negative. Then you can look at CD123, which marks plasmacytoid dendritic cells, which are frequently in groups in there. So you have an aberrant phenotype, you think. So is this lymphoma? So no, it's not, because your primary morphological impression that this is Castleman's disease, highly muscular type, is true. So this is a classical highly muscular unicentric Castleman disease, which has these classical features. You have these condensed germinal centers, you have the expanded mantle cells with this onion ring arrangement, onion skin arrangement of the lymphocytes around it. You may find CD123 plasmacytoid dendritic cells in there. You may find TDT positive cells, something which you have to look out for. You should stain for it, but if you find them by chance, don't get scared. This is not lymphoblastic lymphoma. They occur in small groups in these tumors very often. As we know now, this is actually a tumor of follicular dendritic cells. The B cells and the T cells are clearly polyclonal. It's a neoplasm, but it's not a lymphoma. And this is a very typical feature. Actually, the CD5 positivity is in up to 40% of cases, so this should not scare you. This doesn't make marginal cell lymphoma or mantle cell lymphoma or else. I'm not going to talk about multicentric Castleman's disease, because this would require another half an hour. And because this is a systemic disease where you have an HHV8 positive and an HHV8 negative variety. The only thing which I want to stress here, that the separation into hyaline vascular is unicentric and the plasma cell type is multicentric, makes sense in many cases, but not in all cases. There's a morphological overlap. And the important thing to separate these two disorders is the clinical features with which the patient comes. So you really need also the clinical information to make a diagnosis of multicentric Castleman's disease. So I'm not going to talk about this in detail, just to keep in mind it's not a pure morphological discrimination between these two subtypes. So we stay in the head and neck region. This is a 20-year-old male with a very similar history to the one before. So he had a long-standing, quite large cervical mass, no symptoms, no other lymph nodes. And finally, they decided to take out this lymph node. And you see, you have some germinal centers which look pretty normal. And then you have these large, sometimes coalescent nodules. And you see these here. This looks like there's some germinal center cells in here. And there are mantle cells invading from the side. And this is actually a very typical finding for this very common disorder. So if you look at the immunohistochemical pattern of this, if you do an IgD stain, you see that these IgD positive follicular mantle cells invade and destroy the germinal center, whereas the reactive germinal centers are nicely positive in the mantle, but negative in the germinal center. You see this irregular expansion of follicular dendritic cells. CD20 is positive, but not in the interfollicular areas. And you see that there are a lot of PD-1 positive follicular T helper cells. So this is a very typical finding, very common in young males. And of course, you all know that this is progressive transformation of germinal centers. I always tell my residents, haematopathology is a low power diagnostic area. They always look at me and say, well, if you have all these small lymphocytes and medium-sized lymphocytes and large cells, and how can you say this is a low power pathology diagnosis? Well, I say, if you don't look at low power, you're going to miss the diagnosis because then you don't see the architectural features. But actually, in this case, you really also need to look at the high power, because something which looks very similar may present identical young male cervical lymph node isolated, has these large nodules, and here's accompanied by some histiocytic cells, some epithelioid granulomas which rim these nodules. This is very typical. And you see that this also looks like progressively transformed germinal centers. But if you look closer, then you see a scattering of large cells, and then you see these cells. And if you look at those, which are called popcorn cells or LP cells, then you already know the diagnosis. If you look carefully at the H&E, this is not a lymphocyte predominant Hodgkin lymphoma or nodular paragranuloma, as you may call it. And this is really a disease where you have to look carefully at these nodules. Usually in NLP, you have a tumor mass, which also may be a node in a node pattern, whereas in progressively transformed germinal center, there's more a mixture of reactive and progressively transformed germinal centers, but still take a careful look at those, and then you go on and you do the CD20 stain. You see this partial involvement here on the left upper side. You have these CD21 FDCs, which are very dense, which are kind of irregular here. And then you see these large cells are CD20 and have a halo of CD20 negative T cells, which is not always so nicely demonstrated as here, I have to say. And these are rosetted by PD1 and by CD57. So this is a very straightforward case of nodular lymphocyte predominant Hodgkin lymphoma, which is, I think, in this case, easy to diagnose. It's not always that easy to diagnose because sometimes, and this is from the WHO, a copy from this original publication from Fend et al., that you have, this is the classical pattern, but you may have depletion in B cells. You may have more of the LP cells outside of the germinal center of these progressively transformed germinal centers. And the difficult ones are these, which look like T-cell-rich B-cell lymphomas. Usually should have some nodularity, at least somewhere in the corner, and you have residual B cells. The problem is you have a lousy core needle biopsy, let's put it this way, then it may be impossible to discern between T-cell-rich B-cell lymphoma and this pattern of a T-cell-rich B-cell-like nodular lymphocyte predominant Hodgkin lymphoma. I'm not going to repeat what is written here. You may look at this later on. So the tumor cells have a preserved B cell phenotype. That's the important part. The background has a lot of B cells and FTCs, but the B cells may be reduced in these aberrant patterns. So let's go to the next, which is mantle zones and marginal zones. So this looks a little bit at first glance like a small B-cell lymphoma. You have a residual germinal center here. So there's clearly an expansion of the mantle zone. So you have a small germinal center here. There's another one here. And so you may think, okay, is this mantle cell lymphoma with a mantle zone pattern? But then you see this blue arrow here, you see some larger cells. Again, here you need to take out the 40x magnification. And you take a closer look and you see everything is B cells. So you think, is this a B cell lymphoma? But then you see these ugly looking cells, which are sort of in between classical Hodgkin with Sternberg cells or LP cells. And you have a nodular architecture in this entity, but the cells, in contrast to LP Hodgkins, are CD20 clearly negative. So you go on and you do these things, which is CD15 positive, CD30 positive, and in this case, it was also EBV positive. So the diagnosis here is very straightforward. This is a lymphocyte-rich classical Hodgkin lymphoma. So this may be a mix-up, but in NLP, the tumor cells are in progressively transformed germinal centers. In lymphocyte-rich classical Hodgkin lymphoma, you have regressed germinal centers, expanded mantle zones, and in these expanded mantle zones, you see these cells which have a classical Hodgkin lymphoma phenotype with lack or more or less lack of B-cell markers. This is just for repetition. So this is actually a nice LP cell in a classical Hodgkin lymphoma because it has these folds and really looks like popcorn. This, again, this is also an LP cell, but in this case in NLPHL. So you have here, the main feature is here you have a germinal center B-cell program. So you have a preserved B-cell program. Sometimes you may see a little bit of CD30. There are rare cases which are CD15 positive. There are actually also cases which are EBV positive. But the bottom line is these cells have a preserved B-cell program. On the other side, in classical Hodgkin lymphoma, you have an abrogated B-cell program of CD30, CD50 in many cases, EBV, and you see a little bit of B-cell markers here and there. There are cases which are difficult to classify between these two disorders, but I would say that 95% or 98% you can make easily this differential diagnosis between NL-PHL and lymphocyte-rich classical Hodgkin lymphoma. We stay with the mantle zones. So again, you have a case where you have these expanded mantle zones. You see some residual germinal centers which kind of look overrun. And then you have to say, okay, this does not look normal, even though the sinuses are open. So be careful with these cases. Do some stains, CD20, of course, but this is a stain I also would recommend. So this is cyclin D1. So this is a mantle cell lymphoma with a mantle zone pattern. So I'm sure you have heard about in situ mantle cell lymphoma. How do I differentiate this pattern from in situ mantle cell neoplasia? You shouldn't call it lymphoma anymore, in situ mantle cell neoplasia. Well, this should look like this. You just have a rim of a couple of cyclin D1 positive cells, which are located exactly on the border between the germinal center and the mantle zone. So this is the discrimination here. Again, in situ mantle cell neoplasia, you won't see if you stain for unless you stain for cyclin D1, whereas the mantle zone pattern here you already have a distorted, partially preserved or distorted pattern in the lymph node, which prompts you to do immunostaining. So this is partial involvement by mantle cell lymphoma with a classical mantle zone pattern. If we stay outside of the follicles and go a little bit outside, and we have the marginal zone, under normal circumstances, you don't see the marginal zone very well in the lymph node. You see it best in the spleen. That's where the name comes from, marginal zone. You also see the marginal zone, for example, in the Peyer's patches in the intestine, but you don't see it in the normal lymph node. So this is important to keep in mind. So if you see it and if you have this inside-out pattern, the germinal centers look dark, and you have these pale staining cells outside in the lymph node, this is something which really should bring you to preliminary diagnosis of marginal zone lymphoma. There are differential diagnoses. It's not an easy diagnosis, as we've seen from our studies, but this already brings you into the direction of marginal zone lymphoma. So marginal zone lymphomas don't have a specific immunophenotype. They're B cells without aberrant immunophenotype. So the architecture is very important. So you see CD23, expanded networks of follicular dendritic cells. You see this split up and partially colonized germinal centers, which are BCL2 negative. BCL6 shows the same pattern. CD10 would show the same pattern. Occasionally we see CD43 as aberrancy, but this is not really in many cases. If you have a lot of monotypic plasma cells, they can occur, but if you have a lot of monotypic plasma cells, then lymphoplasmacytic lymphoma, of course, should be on your mind. So nodal marginal zone lymphoma is rare indolent B-cell lymphoma. It's not so indolent as compared to extranodal marginal zone lymphoma. You also have, of course, to think about nodal involvement by mold lymphoma, for example, in the stomach. It has an association with hepatitis C infection. Histologically, it's very heterogeneous, but this pattern, this geographic pattern, is probably the most typical one. It has a non-specific immunophenotype as is listed here, and the mutational profile is only partially helpful. KLF2 can occur in about 20 to 25% of cases, or 30%. BRAF may occasionally be observed in these cases. Also MYD88, which is typical for LPL, has been found in a low number of these cases. So the differential is lymphoplasmacytic lymphoma, especially follicular lymphoma BCL2 negative, especially those with the diffuse or partially diffuse growth pattern. If they do express CD23, move away from nodal marginal zone lymphoma, move towards follicular lymphoma BCL2 negative with STAT6 mutation. That's at least from our experience of our group. Something very similar can be found in a pediatric age group. So if you look at this case, this looks almost virtually identical. Again here, this is a disease localized in the head and neck region. It's almost exclusively in males, and it's almost always stage 1. So morphologically, it's similar to adults, but it has more a pattern of progressively transformed germinal centers and expansion of interfollicular areas. And again, similar to pediatric-type follicular lymphoma, it's a disease which should not be treated unless the patient really has the disease beyond stage 1 or progressive disease. Most of those patients do fine if you excise the node and you don't do anything about it. Still, there are lymphomas, and I'll show you that. So they have an expansion of, here in the higher power, you have the expansion of these pale marginal zone cells, which have this sometimes this monocytoid appearance, which means pale, eosinophilic, broad cytoplasm, medium-sized nuclei, which don't have prominent nucleoli. And if you look at the low power immunostains, which is always very nice, you see again this node-in-node pattern. You have some residual follicles up here, and you have this expanded B-cell nodules with this expanded CD23 positive follicular dendritic cells, like in the adult cases. BCL6 shows that the germinal centers have mostly been destroyed, and the IgD shows a pattern which is very similar to progressive transformation of germinal centers. And these cases also should have, for the diagnosis, a clear-cut clonal B-cell rearrangement. And so this is the summary. So colonization of germinal centers by these mantle zone cells. You may have expression of CD43 again. You have these expanded meshworks of dendritic cells, remnants of germinal centers, and you have a B-cell clone. So if you think what I told you a couple of minutes ago about pediatric-type follicular lymphoma, you may think, aren't these related? If you look at this is a classical pediatric-type follicular lymphoma, and this is a pediatric-type marginal zone lymphoma, but there are cases which have overlapping morphological features. And in a collaboration with Elaine Jeffy, our group, again, under the guidance of Leticia, have produced these very exciting data, which show that basically these two entities, pediatric-type marginal zone lymphoma and pediatric-type follicular lymphoma, have a very similar mutational pattern. There are some exceptions here. This is TNSF14 inactivation and ECDH2 mutations. So this looks like this is a morphological spectrum of one and the same disease. They have mutations, but they have a very indolent prognosis, even without chemotherapy. That's why the separation from adult-type lymphomas is crucial here. So this is really an overlap of two entities with very similar clinical, pathological, and genetic features. So this is just a summary of what we have to look at if we see expanded mantle zones or marginal zones. So we have atypical marginal zone hyperplasia, which can have huge marginal zones, especially in mesenteric lymph nodes. They are polytypic, polyclonal. We have mentioned lymphocyte-rich classical Hodgkin lymphoma with these expanded mantle zones with the rich stomach cells in there. We have mentioned highly investicular Castleman's disease with aberrant expression of CD5, and of course, the mantle zone pattern of mantle cell lymphoma. There's one thing which I forgot in the reactive disorders. Well, not forgot, but I haven't mentioned yet, which is monocytoid B-cell hyperplasia or monocytoid B-cell reaction. These are these pale staining cells in the sinuses here. They are associated with a variety of infections, infectious mononucleosis, toxoplasmosis, and they are B cells. They may look very impressive, but they are clearly reactive. And this is an extrafollicular way of B-cell maturation, and they have a specific immunophenotype. But if you look at them, you see them, these are monocytoid B cells. Well, usually. So that's why I'm sharing this case with you. So this is a young lady with a history of lymphoma 15 years ago. That's actually the only non-head and neck lymph node which I'm showing you. And you see this florid follicular hyperplasia, and then you see this expanded monocytoid B cells here, which look a little bit irregular compared to normal monocytoid B cells. And you see many of those have features of monocytoid B cells with this pale cytoplasm, medium-sized nuclei, and then you have some weird cells like these large cells here. You do a CD20, and these large atypical cells with these kidney-shaped nuclei stick out. And then you do some more stains. This is CD30. And this is MUM1 and ALK, ALK protein. So this is a recurrence of ALK-positive ALCL 15 years after primary diagnosis, hiding in monocytoid B-cell reaction. You sometimes may see this with Hodgkin lymphoma, classical Hodgkin lymphoma. You sometimes may see this with anaplastic large cell lymphoma. So if a monocytoid B-cell reaction looks weird, it may either go into the direction of marginal zone lymphoma, which may have a very prominent monocytoid component, or it may be something bad lurking in between these monocytoid B cells. Let's go to the next structure of the lymph node, which is the interfollicular area. So this is a 76-year-old male, and this again is something which as a general pathologist you will encounter frequently, because this is a sentinel, this is an enlarged node in a patient with melanoma, and they ask for metastatic melanoma, and you can say, well, there's not metastatic melanoma, at least not in this section. You see some reactive germinal centers, and you see that the interfollicular area seems expanded. So here's the germinal centers, and you see here this expanded zone, some of which again looks a little paler. Here the cells are a little bit medium-sized, and wonder what's in there. And then if you take some immunohistochemistry, you see you have an expansion of CD20 positive cells between these reactive-looking germinal centers. You have a lot of CD3 cells, and you see that CD23 is increased. So not just in the follicular mantle, but going beyond the follicular mantle. And then if you look at CD5 and you compare CD5 and CD3, CD5 and CD3 look different. So there is a double positivity for CD5 weak staining cells, which are the B cells, and strong staining cells. So this is an involvement of a lymph node, a partial involvement of a lymph node by CLL, SLL. So this is a very straightforward diagnosis, which may also be very subtle. And if it's too subtle, then you will miss it. And if you miss it, it's not a problem, because we have cases like this here. So you shouldn't stain every reactive case for 20 immunohistochemistries unless you want to get your immunohistochemistry lab get mad at you. But these are cases which have been described by Sarah Gibson and Steve Swerdlow, where you look at a normal-looking lymph node and you happen to do immunohistochemistry, you see that there are some CD5 positive B cells. So this is what we nowadays would call a monoclonal B-cell lymphocytosis manifesting in the tissue. So these patients frequently have preserved architecture, have a minor population of these CLL-like cells, which you may find in peripheral blood. That's a very common finding. You also may find in the lymph node. And what's shown very nicely here, if these lymph nodes are small and if you don't have proliferation centers, these patients don't progress, so they do very well. So this is really actually a tissue manifestation of a early neoplastic clone, which is an equivalent to this monoclonal B-cell lymphocytosis of CLL type. So also not something which you should actively be looking for. We stay with the interfollicular area, and this is a cervical node again from a young male, and you see there's a more or less preserved architecture. You see reactive germinal centers, reactive looking germinal centers. You see areas which look like monocytoid B cells, and you see that the interfollicular areas look pale. And then you go closer and you see that this is a mixed pattern. You see some large cells, you see a lot of plasmacytoid cells, some which look like plasmablasts, you see a lot of mitosis, and then you look even closer, and then you start to get scared because you have two cells up on the left, which look pretty much like very good examples of classic Reed stomach cells, and other ugly looking cells, and you wonder whether this could be an interfollicular Hodgkin's lymphoma. And then what you should do is you should do a couple of things. You should do EBRS, something which I recommend a lot, EBV staining or EBV in situ hybridization. And you see that these cells, these atypical cells, co-express CD30 and CD20. CD30 is like plus minus with varying intensity, and they're completely CD15 negative. And then you do LMP1, which I haven't shown here, but latent membrane protein 1 of EBV and EBNA2. And all these markers are positive. So this is infectious mononucleosis in the lymph node. Sometimes if you encounter this in an older patient, this reactivation, and we see these cases once in a while, it may be very hard to separate from an EBV-positive lymphoproliferative disorder or Hodgkin lymphoma or something else. So if you have a disorder which looks kind of weird, may look reactive, but not quite, do an EBV stain and then go on determine the latency. So EBNA2 and LMP1, if you have latency type 3, the patient is either immunosuppressed or he has infectious mononucleosis or EBV reactivation. These rheus-dermatoglycan cells typically don't express CD15. So if you see this in the tonsil, you used it because we frequently see infectious monos in the tonsil, but it may come across in the lymph node as well, and then you should just be aware not to overdiagnose this as lymphoma. We stay in the interfollicular area. So this is a 36-year-old male with recurrent lymphadenopathies, clinically suggestive of non-Hodgkin lymphoma, and he had several lymph nodes biopsied already. He has a history of chronic hepatitis C and liver cirrhosis. He already had a splenectomy. And then you receive this quite large lymph node, and you think, well, what could this be? And then you go on and you see germinal centers which look like a little bit regressed, and you see the interfollicular areas expanded, and they look like plasma cells. And if you look closer, these are all a lot of normal looking plasma cells. And then you do some immunostaining, you see CD20, you see an increase in CD20 positive cells, but fairly normal looking follicles. You do CD3, not very exciting either. You do CD23, you have nice follicular dendritic cells. You do IgD, you have preserved follicular mantle cells. And then you do IgG and IgG4, and you have tons and tons of IgG4 positive plasma cells, not in the follicles, because they don't have anything to do with this disorder, but outside of the follicles. And you have this expanded interfollicular area. Frequently, these lymph nodes are very much fibrotic, have a thick capsule. We just received a case in consultation today, which looks like a Hodgkin lymphoma if you look at the capsule, but has also these IgG4 positive plasma cells. They are polytypic, so kappa, lambda equally distributed. The germinal centers are BCL2 negative with equality, so everything is fine. So this is lymphadenopathy and IgG4 related disease. The patient turned out to have IgG4 related disease. So this is from a very nice paper from the Mass General Hospital, which shows that if you have capsular parenchymal fibrosis and you have a lot of plasma cells with a high ratio of IgG to IgG4, this is very suggestive of IgG4 related disease. Also, if you have, like in this case, this massive expansion of plasma cells in the interfollicular area. But if you just have IgG4 plasma cells in the follicles themselves, this has nothing to do with IgG4 related disease. So this is non-specific. So take a look at this paper. I cannot go through this in detail, but it should be in the interfollicular area, it should have a high IgG-IgG4 ratio, and it should have fibrosis often in the capsule. Also mind that some B-cell malignancies also may show predominance of IgG4. This especially has been shown for cutaneous marginal zone lymphoma or lymphoproliferative disease, as it's going to be called now. We stay with the lymph node. Now, this is a case which is a common misdiagnosis in our consultation practice. Well, not common, but we have seen several of these cases which were diagnosed or with a differential diagnosis of lymphoma. You see these pale staining areas with necrosis. You have a lot of apoptotic bodies. You have extensive necrosis. You have some fibrin thrombi, you have histiocytes with crescentic nuclei, so you think this could be lymphoma. Then you have a high proliferation rate, you have a lot of plastic cells, you have this necrosis, the lymph node architecture is altered, and you think this could be T-cell lymphoma, partial involvement. And actually, this was the diagnosis which we received this case with. But then you should do CD123. So this is a classical case. You see this sheets of CD123 positive cells around these necrotic foci, which typically lack neutrophilic granulocytes, which you would expect in necrosis otherwise. And so the diagnosis here is necrotizing histocytic lymphadenitis, or Kikuchi-Fujimoto disease, which is mostly young females. They have fever, isolated lymph node, it's taken out. Systemic symptoms other than fever is rare, and you have these partial involvement with this diffuse, very ugly looking proliferation with coagulative necrosis. It really may look like a high-grade lymphoma. So please remember to stay for CD123 and or TCL1 to highlight the plasmacytoid dendritic cells. They may be myeloperoxidase positive. And they're usually polyclonal, but don't do clonality because we have lots of reactive disorders where a clone may crop up, either B or T cell. But here the clinical history is also very, very typical. So if I see something like this, and then I look at the sheet, at the name, so we often have, they often have an ethnic background of Asian origin. So this is something which is, that's why it was described in Japan. But it's something you have to look out because this is a classic pitfall to overdiagnose lymphoma. So I have spent now 50 minutes and I would have another couple of slides for extranodal lesions. But if you're exhausted already, we can stop here and go for the questions. What's your decision, Willie?
No, please go ahead, Falko.
Okay, so I will continue. I hope I won't get hoarse. So again, we stay with cases. So this is a 5-year-old girl and had tonsillitis, had sleep apnea. I didn't know that this can actually happen in kids as well. She was probably snoring as well. And so a tonsillectomy was performed. And if you look at the tonsils, which is something which you see every day, of course, you see that some of these germinal centers look weird. Yeah, this was a case from the workshop in Istanbul, a very nice case from Thierry Molina. You say, this looks more like what you expect, the starry sky pattern. These look very pale and they look very monotonous. And then you do a BCL2 and you get frightened and say, okay, is this follicular lymphoma? You do a BCL2 translocation, it's negative. And then you do a MUM1 stain and these cells are strongly positive. In this case, there was no MUM1 break, but there was an IgH break detected. So this is actually a provisional entity in WHO classification, which is large B-cell lymphoma with IRF4 rearrangement. We think that some of these rearrangements are cryptic because if you look at the IRF4 gene, many of those actually have mutations due to aberrant somatic hypermutation. So this is also children and young adults mainly, can also occur in young adults, typically Waldeyer ring, head and neck. They are either follicular grade 3A or B or diffuse. Many of those actually are follicular and diffuse. They're BCL2 positive in many cases, not all of them. They're usually CD10 positive and BCL6 positive, and they have strong MUM1 because of deregulation of MUM1 IRF4 by this translocation. They may also occur in nodes, of course. This is from WHO, again, a tonsil case, but we have seen very nice cases also in cervical nodes. They seem to be more aggressive than other pediatric-type lymphomas like follicular lymphoma, pediatric-type, or pediatric marginal zone lymphoma, but at least when they're treated, they have done very well. So this brings us to what do we find in the Waldeyer ring in the tonsil? Well, we find a lot of things, and but usually we don't find what we would expect in mold location. We don't find mold lymphomas. They're virtually non-existent in location. We see a lot of lymphomas in the tonsil, most of them, and there are very few larger series out there. That's why I have this not very good copy from a paper from 2001. 60 to 80% are diffuse large B-cell lymphomas. What we frequently see is mantle cell lymphoma. So this is something which is actually quite common. The patients have disseminated disease, but the tonsil is taken out first. We often have involvement by CLL. And in children, we may have the IRF4 large B-cell lymphoma, of course. And we also may encounter classical Hodgkin lymphoma and also nodular lymphocyte predominant Hodgkin lymphoma, but beware not to fall into the trap of an EBV-related disorder. I will come to that later. In one series, About a third of them were actually from the lymphocyte-rich classic Hodgkin lymphoma variety. Most of these tumors, except for mantle cell lymphoma and CLL, are actually low stage. But we can also encounter other cases. This was not this case, but this was one case which I still remember. It was almost exactly identical to this. It was a 91-year-old lady with an ulcerated lesion in the tonsil. She had no symptoms otherwise. This ulcer was painful. The tonsil was taken out. And you find a lot of ugly-looking cells. I don't have the high power here, of ugly-looking cells, which are positive for CD30, variably positive for CD20, and then you do a CD30 stain and LMP1 stain, and these are all EBV and LMP1 positive. In this case, it was EBNA2 negative, but they occasionally may be EBNA2 positive. It's just the ulcer, and the ulcer is really walled off, demarcated by a wall of CD3 positive cells. These ulcers typically occur in the mouth, in the tonsil. They also may occur in the skin and may occur in the gastrointestinal tract. So this is mucocutaneous ulcer, EBV-associated mucocutaneous ulcer. It's a localized EBV lymphoproliferation in elderly patients or iatrogenically immunosuppressed, for example, methotrexate for rheumatoid arthritis. This is from an image from a review we did together with Stefan Deutschinow, who described this first, together with in Elaine Jaffe's group. You have this ulcer here on the tongue. You have the demarcation by small T cells. You have ugly-looking cells, many of which look Reed Sternberg-like. They have EBV and LMP1, in this case also EBNA2 positivity. The differentiation from EBV positive DLBCL and polymorphic LPD is not very easy, and best is to really correlate this not only with morphology and immunophenotype, but also with the clinical features. If it's a localized ulcerated lesion and you have some kind of iatrogenic immunosuppression, or it's a very old patient, you better take one step back and call it mucocutaneous ulcer EBV associated. Just something before we finish, a couple of cases to teach some lessons. This is also tonsillar biopsy from a 45-year-old male, and it suggests what this could be. So according to statistics, it should be diffuse large B-cell lymphoma, right? But if you look at the nuclei, again, you have these kidney-shaped, horseshoe-shaped nuclei. And then if you do the immunostaining, so this is CD3 positive, CD30 very, very strongly positive. And this is the type of strongly positive which you need for this diagnosis. This is an anaplastic large cell lymphoma ARC negative, which manifested in the tonsil and had a DUS22 iron 4 break. This is the subset of ARC negative ALCL, which is associated with a good prognosis in most patients. We stay with the pitfalls. I ask you a question. What do you think this building is? Any ideas what this might be? Of course, this is the Eiffel Tower. So sure. Well, it's actually not. This is Sydney Harbour Bridge. So if you just look at one feature, you may easily be misled. And that's the same with diagnosis of lymphoproliferative disorders. So this is a very classical case, I would guess. Is a 50-year-old female with dry mouth and xerophthalmy. And she has this lesion in the parotid. And you see this irregular lymphoid aggregates. And then you see this spindle cell proliferation within the lymphoid cells. And this is actually a very classical lesion. So this is CD20. And these cells invade, the CD20 positive cells invade the epithelium. And you see this expanded epithelial proliferation. So these are typical lymphoepithelial lesions, which you would call myoepithelial cylindritis. And in this case, there was a kappa light chain restriction and there was a clear B-cell clone, no aberrant immunophenotype. So this is, of course, mold lymphoma, extranodal marginal zone lymphoma in the background of Sjögren's syndrome in a patient with Sjögren's syndrome. And here you see a nice B-cell clone in this lesion. And this is another one. So this is a 70-year-old female which has a swelling of the lacrimal gland. And you see again here the glands, and you see this monotonous lymphoid infiltrate. You don't see lymphoepithelial lesions here, but they not necessarily have to be there. And then if you look closer, you see these cells, very monotonous. So this could well be marginal zone B-cell lymphoma. And then you do some immunostains. Proliferation is actually higher than you would expect. And you have aberrant expression of CD5. Then you will say, you have read your papers, CD5 expression can be observed in a part of extranodal marginal zone lymphomas, and you're completely right. This has been published, and these cases are associated with more extensive disease. But still, I would recommend you see also this FDC proliferation in CD23. Not just stop here, but do a cyclin D1 staining. This is actually an involvement of the lacrimal gland by cyclin D1 positive mantle cell lymphoma. And if we look at our consult practice in the cases which we see from our ophthalmology hospital, which is huge in terms of lymphomas, we actually see a high frequency of cases which present with nodal type lymphomas in this location. So not everything which arises in a salivary gland or in the ophthalmic region is actually a multiple lymphoma. So pitfall, overinterpretation of isolated features. Just think of it, no single clinical, morphological, immunophenotypic, molecular feature is specific for any entity, virtually no, yeah? So nodal type lymphomas occur at extranodal sites. Lymphoepithelial lesions can be caused in reactive disorders, in myoepithelial lymphadenitis without clonality. It can occur in other lymphomas. Follicular lymphoma, as I've shown, can be BCL2 positive or negative. Mantle cell lymphoma can be cyclin D1 positive, but there are also cyclin D1 negative cases. MYD88 mutations not only occur in lymphoplasmacytic lymphoma, but also in other types of B-cell lymphoma. And as you know, the T1114 translocation is also found in multiple myeloma, which then is strongly cyclin D1 positive and may strongly express CD20. Then you don't want to be you don't want to diagnose mantle cell lymphoma if it's multiple myeloma, of course. So this is something which I want you to keep in mind. So our approach to difficult cases is get the clinical history. I know you probably get the same clinical histories as we do sometimes. Lymph node, malignancy, question mark, lymphoma, question mark. But in many cases, you really need the background information. And if you call them, tell, oh yeah, the patient had 2 kidney transplants, this is on methotrexate and steroids or whatever. So then you know, okay, that's why you look for EBV in this lesion. Then, of course, we start from a good morphology and a systematic approach, which I tried to show you. Start with the low power view, start with the architecture, because if you go right into cytology, you may miss very important clues for the diagnosis. Of course, immunohistochemistry is a mainstay of diagnosis, determination of dominant cell type B versus T. Immunoarchitecture is very important, as I showed you, for the marginal zone lymphomas. Light chain restriction is very important, and determination of aberrant immunophenotype. Although, unfortunately, not every lymphoma does us the favor to have an aberrant immunophenotype. And remember that molecular diagnostics may frequently solve the problem, but not always. The main pitfall, in my opinion, is to do clonality and to overinterpret clonality in reactive lesions, especially in the extranodal location. So clonality interpretation, if clonality interpretation is done in the clinical chemistry lab, then this is bad, because you really need to put the two things together in order not to over or underinterpret these findings. With that, I'm done with my talk. I just would make some announcements. It's probably too late to travel from South Africa or wherever you are to Lund in Sweden. There's the European Bone Marrow Working Group course and workshop, which can be also seen online, virtually. It's a very good course. Mate and Anna Porvit have organized this course. It's a fabulous location, and it's going to be a fabulous course. So it's both for beginners as well as for experts. The topics are myeloid neoplasms, AML, MDS, and also T-cell infiltrates in the bone marrow. And what you should not miss at all, not just for one of the best touristic places to visit in the world, in my opinion, which is Florence. but also their best haematopathology meeting, which is the EHB meeting, European Association for Haematopathology, which is going to take place from 17th to the 22nd of September in Florence, Italy. Save the date here. This is also going to be a very important meeting with a lot of exciting developments if you think about the upcoming classifications. And with that, I would like to thank you, and I hope I haven't mistreated you too long. I stand at 54 minutes now, and I hope you enjoyed the talk, and I'm very happy to take your questions. Thank you very much.
Thank you, Falko. We'll thank you later on. Much appreciated. If we can you see the chat function?
Yes, I have the chat already
okay,
up here, so I will stop here, so and then I can take a look at the questions. I hope there was something there for everybody. It was a very diagnostically oriented and not so much scientifically oriented talk, but I hope you appreciated that.
No,
so the first question is, can you use STAT6 immunohistochemistry for STAT6 mutations? We don't use it, and perhaps Letitia, who is in the talk, can answer that, but we do not use that, and it cannot be used. STAT6, it's not like the STAT6 in the solitary fibrous tumor, where of course it's very good. The next question looks like from Japan, perhaps, I don't know. We got so. In the case of IgG4-related lymphadenopathy, is it worth doing HHV8 stain? We will probably do it. I mean, we don't have a very high incidence of HHV8-related Castleman's disease, but this is something which you should not miss. And IgG4-related disease can have Castleman-like features. I completely agree. And if I have Castleman-like features and lots of plasma cells, I routinely do HHV8 staining. So I would agree on that, even though the HHV8 positive plasmablastic type of multicentric Castleman disease has different morphology. I didn't go into detail because it's a systemic disease from the beginning, but I think this is a very wise thing to do. So the next question, what is your opinion, CD20 negative diffuse large B-cell lymphoma, does it exist? Absolutely. So we see it frequently, of course, after rituximab treatment, but you also may see it up front. So before you can do other B-cell stains, of course, you have to think about plasmablastic lymphoma, which is usually CD20 negative. But you may have something which is not plasmablastic lymphoma and still CD20 negative. But if it's primary diagnosis, you really have to rule out plasmablastic lymphoma, which may not be so easy. So you should do stains for MUM1, you should do stains for CD56, which may occasionally be positive. You should stain for MYC, because many of these cases have MYC translocations, and beware that many plasmablastic lymphomas actually have aberrant expression of T-cell markers, which can really cause problems. So do MUM1, do the P-cell panel, do CD79A, CD22, PAX5, of course. But it can exist, it's rare, but it does exist. Yeah. Another issue, of course, is ALK positive large B-cell lymphoma, which is also negative usually. How often do you see even negative plasmablastic lymphomas? Yes, we see them. We don't have that large experience really say, okay, it's 30%, or it's 20%. It depends, I think, a lot on the epidemiology of the population which you serve as pathologists. So if you have a high frequency of HIV infection, you will have a high frequency of EBV positive cases, but you do have EBV negative plasmablastic lymphomas. In these cases, in my opinion, it's very important to rule out multiple myeloma, because you may have patients which present with extramedullary infiltration, even though this is unusual, but you may see that. And especially in patients which have been treated for multiple myeloma, now due to the improved treatment of multiple myeloma, we much more frequently see extramedullary relapses in patients with multiple myeloma. They may have a completely negative bone marrow, but they relapse extramedullary, and they are morphologically, immunophenotypically, virtually indistinguishable from plasmablastic lymphoma, except for the fact that some myelomas, about 30%, express cyclin D1 strongly due to 11-14 translocation or to trisomy 11. These cases, plasmablastic lymphoma is negative for cyclin D1, but this can be a challenge. Okay, in a resource-restrained setting such as South Africa, there are many of these investigations that are not available to us, and further budget cuts are expected to worsen the situation. What are the 5 to 7 most valuable immunohistochemical stains that you recommend? That's a very, very difficult question. I mean, we take a stepwise approach usually, which is guided by the morphology. So if we have a high-grade morphology, we start with CD3, CD20, and perhaps CD30. If we have a low-grade morphology, we do CD3, CD5, CD20, CD23, cyclin D1. If it's more like a follicular lymphoma, we do BCL2. We do a follicular marker like CD10 or BCL6. I would say that if you really have resource restriction, then in many cases you get along very well with a handful of 5 to 7 markers. You don't need to have the full panel of 15 stains to diagnose diffuse large B-cell lymphoma, of course. And currently, the Hans algorithm, we do it like CD10, BCL6, MUM1, but it's not recommended. And we add the MIC in order not to overlook double hit lymphomas, so which are BCL2, MIC1 translocation to get a MIC translocation together. One thing, especially for countries which have a high incidence of immunosuppression, one thing which I would fight for with my budget director till the end is EBRS, EBV in situ hybridization, because we really can do a lot of misdiagnosis by overlooking or misinterpreting EBV lymphoproliferations, which can look very ugly. So I think EBV, especially for countries which have also, for example, a higher Asian population, Asian ethnicity, I think to have EBRS is mandatory for every pathology lab. I think this is something which we repeat over and over again, because this is really crucial and it will solve many cases which are morphologically very difficult. I mean, you have CD20, you have CD30, you have CD3, you have high proliferation rate, and you still don't know what it is. So do an EBRS. I think this is something which you really should have. Next question. Doing CD5 in DLBCL in developed countries. Well, we actually usually don't do CD5 in diffuse large B-cell lymphomas because it's associated with an ABC type, it's associated with the worst prognosis and certain clinical pathological features, but it has no implications, and it's not a separate subtype, so we usually don't do it. It's a different story if you're a patient with a history of CLL, and this might be Richter's transformation, and you will do CD5. Or if it may look like a pleomorphic mantle cell lymphoma, they will do CD5 and cyclin D1, but we don't do it routinely in diffuse large B-cell lymphoma. We are actually relatively restrained in our use of immunohistochemistry. So it's not something which is mandatory, in my opinion. Next question, after all the flattering. Thank you very much. There's a comment which I can only underline. The most important immunohistochemistry is a very good H&D. One of our senior pathologists, very experienced senior pathologist, always says, my favorite immunohistochemistry is the H&D, which I can only agree. I mean, and you've seen I've always started with morphology, and I always try to get a good morphology because this can resolve a lot of questions. Which T-cell lymphomas do you encounter most commonly in the head and neck in your experience? Well, we encounter few T-cell lymphomas. I showed you this ALCL case, which is exceptional. Of course, especially in Latin America or in East Asia, you will have cases of nasal type T and K cell lymphoma. So if you have a lymphoma, we will do, and it's CD3, or if something looks like a lymphoma and it's CD3, then you need to do CD56. You need to do an EBV stain, EBV in situ hybridization, not an LMP, because many of those are LMP1 negative. So this is something to think about. Other T-cell lymphomas, in our experience, are actually rare. So also something like angioimmunoblastic T-cell lymphoma, which is the most common T-cell lymphoma in our practice, you may encounter, of course, in a head and neck lymph node, but extranodal in the head and neck, it's very unusual. You find it in the skin sometimes, but the nasal NK T-cell lymphoma, EBV positive nasal type, of course, is important. Any further questions? Or you're already exhausted, which I can imagine.
Yeah, I don't see any. Falko, thanks again. I think I speak on behalf of all of us to say we are all really glad that we know there are hematopathologists out there. Thank you very much for your systematic approach to the way you handled such complicated matters, your beautiful H&Es and immunohistochemistry. And I think look back to a comment from Peter Morgan that it was really one of the lectures you could follow. And I think what Guy said, that is the true indication of an expert. If you can explain something that even an unknowledgeable person can follow. Falko, for that regard, thank you for your preparedness, your willingness to participate. We were really spoiled today and we appreciate it a lot. Thanks again.
Thank you very much once more for the invitation. It was a pleasure to talk to you across Zoom, which we now have all got used to in recent times. I hope you enjoyed the talk. And if you have any questions, you can also drop me an email. And if you find time to go to the 2 meetings which I mentioned, I think they're really worthwhile. And this is probably the best you can do if you want to get the newest in hematopathology, these 2 meetings.
Yeah, absolutely.
Thank you very much.
Yeah. Yeah. And thank you, Falko, and to all the colleagues who attended throughout the areas. Thank you very much, and please be on the lookout for our next talk. Thank you very much, and goodbye. Thanks again, Falko.
Bye-bye. Thank you.